Today, let's discuss high-grade thyroid carcinoma, or poorly differentiated thyroid carcinoma. Its definition has changed recently, and these updates are now incorporated into the latest WHO tumor classification.
As disease classification becomes increasingly complex, thyroid pathology has expanded as well. There are currently 13 different follicular cell-derived thyroid tumors listed in the WHO system, and this number will likely increase in the next edition. Many of us miss the old days, when clinicians broadly divided thyroid cancers into only two categories: well-differentiated thyroid carcinomas, slow-growing and rarely fatal; anaplastic thyroid carcinoma, highly aggressive and almost universally lethal. While simple, this dichotomy overlooks an important intermediate group with histologic and prognostic features between the two extremes. This group is now recognized as poorly differentiated or high-grade differentiated thyroid carcinoma, and it will be our focus today.
The WHS system divides high-grade non-anaplastic thyroid carcinoma into two categories: poorly differentiated thyroid carcinoma, PDTC, and high-grade differentiated thyroid carcinoma, HGDTC. These terms are often used interchangeably in practice, which can be confusing. For today's discussion, we will follow WHO terminology. The first group is poorly differentiated thyroid carcinoma. The diagnostic criteria for PDTC were established in 2007 in Turin and are still referred to as the Turin criteria. PDTC requires A. a specific growth pattern, solid, trabecular, or insular; B. absence of papillary thyroid carcinoma type nuclear features; and C. at least one of the following three features: convoluted nuclei, which are small, round, hyperchromatic nuclei with irregular contours, equal to greater or more than 3 mitoses per 10 high power fields, and tumor necrosis.
In this picture, we see tumor-forming irregular nests, or insular growth pattern, meeting the first diagnostic criterion. The tumor cell nuclei are small and hyperchromatic, lacking papillary thyroid carcinoma nuclear features, meeting the second diagnostic criterion. In addition, these nuclei are convoluted, small, hyperchromatic nuclei with irregular nuclear membrane, meeting the third diagnostic criterion. Based on Turin criteria, this tumor is poorly differentiated thyroid carcinoma. In other areas, there is necrosis, further supporting the diagnosis of poorly differentiated carcinoma. Now take a look at another case. At low power, we see solid and trabecular growth pattern and large areas of necrosis, meeting the first and third diagnostic criteria. At high power, these nuclei are large, pale, small nucleoli, and nuclear membrane irregularity. So these nuclei have PTC nuclear features, which means we cannot classify this tumor as poorly differentiated carcinoma. Prior to 2021, this tumor would be classified as solid variant of PTC. Clinicians questioned whether tumors like these behaved less aggressively. Research from Dr. Gossin's group at Memorial Sloan Kettering showed that many thyroid carcinomas that did not meet Turin criteria nonetheless behaved just as aggressively. They found that aggressiveness correlated best with mitotic rate greater than or equal to 5 per 10 HPF and/or tumor necrosis, regardless of growth pattern or cell type. This led to the recognition of a second category, high-grade differentiated thyroid carcinoma, which is not poorly differentiated by histology, but with the presence of increased mitotic activity and/or necrosis. Here we see a picture of follicular neoplasm with a thick capsule and irregular tumor nests inside the capsule. High power, we see follicular growth pattern with no PTC nuclear features. There are two irregular areas of necrosis. The presence of necrosis alone is diagnostic of high-grade papillary thyroid carcinoma. Here is another case. At the left of the picture, we see papillary growth pattern. In the right, we see large areas of necrosis. Again, this is a high-grade differentiated carcinoma.
Similarly, mitotic activity greater than or equal to 5 per 10 HPF, even without necrosis, is sufficient for this diagnosis.
Immunohistochemistry is usually not necessary for diagnosing high-grade thyrocarcinoma. When performed, tumor cells are typically positive for keratin, TTF1, PAX8, and thyroglobulin. The Chi-67 index is usually 10 to 30%. Clinically, these tumors are aggressive, with prognosis intermediate between well-differentiated carcinoma and anaplastic carcinoma. Many patients do not respond well to radioactive iodine, and recurrence and metastasis are frequent. Mean disease-specific survival is approximately 5 years.
Now let's look at a thyroid tumor from a 19-year-old patient.
Low-power examination shows a follicular neoplasm with a capsule and irregular nests penetrating through it. The tumor is a follicular neoplasm with no papillary thyroid nuclear features. High-power fields reveal 6 mitoses per 10 HPF. By adult criteria, this would be diagnosed as high-grade differentiated thyroid carcinoma. However, pediatric thyroid carcinoma behaves differently. Studies show that in patients younger than 21, neither increased mitosis nor necrosis reliably predicts adverse outcome. Therefore, Turn criteria still apply to diagnose PDTC in children, but high mitotic activity or necrosis does not necessarily indicate high-grade behavior in differentiated thyroid carcinoma for this age group. Based on current studies, this groups of tumor in pediatric patients are associated with an overall excellent prognosis. To wrap up, high-grade follicular cell-derived non-anaplastic thyroid carcinoma includes 2 categories: poorly differentiated thyroid carcinoma, PDTC, defined strictly by Turn criteria, and high-grade differentiated thyroid carcinoma, HGDTC, defined by mitotic activity of greater than or equal to 5 mitoses per 10 high-power field and/or tumor necrosis, regardless of growth pattern. Importantly, mitotic activity and necrosis carry different prognostic significance in pediatric patients under 21 and must be interpreted with caution to avoid overtreatment.